Welcome, Sashan.
Thank you so much, Ellen, and thank you to the whole community. Sheena, am I able to be co-host to share my screen?
You should be co-host now.
Great, thank you. Good morning, Brian. So I'm channeling the energy from spending time in Alaska with Alan and Judy and the whole community there in Fairbanks, where you have lots of light for a great majority of the time. And so I feel like you all are these sources of light for this work in schools. And so much of what we've learned has come from tragedy, and we try to find the silver lining. And I'm going to talk a lot about our communities here in Northern California and California in general. I know some of you are from California. Many of you have been here. It's a wonderful place to live. We like to call it the bluest part of the Blue Island in terms of political thought. And yet we know that mental health is part of overall health, and mental illness does not discriminate, and suicide does not discriminate. So we've learned quite a bit. We've learned a lot of, I guess there's been a lot of silver linings, let's say that. So what I'm going to do today is I'm going to take you through where we've been as a community in California. I'll present a little bit in terms of statistics, and then I'm going to get into what we learned here in the community of Palo Alto and how that has then been applied to the work in the state and nationally and internationally with regard to our toolkit, which is a convening document of best practice. And I will show you a few slides from that as well. So with that, this is where I'm actually in my office on campus right now at Stanford. And I'm just really honored to be here with all of you. And it's just been a wonderful collaboration with Brian and Alan and several of you who I get to hear. And now with the refugee work, the SBIRT and others, it's nice that we can connect virtually, and especially this year at the virtual symposium. So first, I want to really have this moment to express gratitude to all the different districts. This is a smattering of the ones we've been working with for the last 10 years or so, all over the Bay Area here in San Francisco. But this one in particular is very interesting because it's the HEARD Alliance, which is the Healthcare Alliance for Response to Adolescent Depression, which was a collaboration amongst mental health, schools, and primary care that came together after the first suicide clusters here in 2009. And with Santa Clara County, we have 32 school districts. And we have a partnership there where we work with the different school districts in implementing the law, which is the suicide prevention policy that all of California local education authorities have to implement. So that's been a partnership based on our work in schools. And because you all here work in schools as part of school-based family counseling, I'm going to be highlighting some of the lessons learned that we have, I think we've learned. They've been important lessons. We've made some mistakes along the way, and from that, hopefully we have some wisdom around how to bring some of the stakeholders in, because whenever we talk about suicide, there are those who still really feel very stigmatized and very strong about the idea that if you introduce the term suicide in a young person's mind, you're actually planting the idea or planting the thought. Well, we have a whole, unfortunately, bit of data on how suicide rates are going up all over the United States. And in particular in California, there's a strategic plan that some folks from my group were involved in developing. And the name of the plan is called Striving for Zero. And so here's the link, and you'll have the slides. So I provided technical assistance along with two of my colleagues here at Stanford. And the idea was to provide the California Department of Education with the oversight of suicide prevention policies as part of one of its major goals, which was to increase development and coordination of suicide prevention resources. And I realize many of you are coming to us from around the world. Some of you will watch this as a recording. So I won't spend too much time on the specifics, but I thought the headings were important because what we have learned when we started to do this work in earnest, when I got involved in 2009-10, there was already a lot of material out there. And we were asked on the university side to bring the best practices from what was learned in Europe, as well as at other places in the United States and around the world, Asia, Southeast Asia in particular, where they've really dealt with a lot of youth suicide. I know that's one place we would gather in Southeast Asia for this particular conference. So goal 5 here, I think, is relevant, which is to empower people, families, and communities to reach out for help when mental health and substance use disorder needs emerge. So I'm hoping that that has some relevance to your communities, wherever they may be. So just looking again, focusing on youth. This is a slide from this group called childtrends.org, and they took the YRBS, which is the Youth Risk Behavior Survey from the CDC, which is done every 2 years. And you can see the numbers here back in the 90s. Almost 30% of our youth were thinking seriously about attempting suicide, with about 7% making an attempt and about 1.7 making an attempt serious enough to land up in the emergency department.
Excuse me, Shawshank, I don't think your slides are advancing.
They're not advancing. Let's see. Which was the last slide that you saw?
We need you to push start from the,
Yeah, I still see the title slide. Now it's
Yeah.
advanced.
Go
Okay,
back to your start from the actual presentation.
let's see. All right, so is this where you are right now? You're still on my title slide right here?
Yeah.
I was still on the title slide, yeah.
All right, let's see if I can.
Just move to the next
Just
one
push
you want.
that. No, right where you were before. The
Yes.
play from start.
Yes. So this is what I did, and I think this was the thing that didn't allow the slides to advance.
Okay, that's very strange.
So is this slide advancing right now?
No.
No.
Yeah, so let me try something else. Sorry about that. Here I am droning on about the various
Yeah,
things.
that's it.
And
Then that. Go to full screen.
okay, now let's see. I might, just in the interest of time, do this. You'll still see me, you'll still see my small slides on the slide there, but you can see this now.
Yes, yes, I can see that.
All right. So this is where I am broadcasting from.
Yeah.
And there are my acknowledgments to the different school districts. And I was talking about the HEARD Santa Clara County Partnership, which is what we have been doing with the different school districts. And this, can you all see this okay?
Yes.
So this is the Striving for Zero, the strategic plan for suicide prevention, with the link, again, with the highlight being to empower communities to reach out for help. And so here was the graph that I was on. Thank you for pointing that out. But the idea here is that the trend is going in the wrong direction. So starting with about 30% back in the 90s, and then we came down. This is people who have thought seriously about taking their own life in grades 9 through 12. And this number is now going up 17% in 2017, up to 19% in 2019's data. This number, those who actually attempted suicide, has stayed pretty consistent throughout the US, between 7 and 9%. And that indeed is where it is now, between 7 and 9%. And then this trend line, when I got involved in the work, it was around 2009, close to 2%, and it's been creeping upward. So this is looking at specifically those students in California in grades 9 through 12 in public school, well, actually in any school, because it's a self-report, including private schools, for the trends in suicidal thinking and serious suicide attempts. So here's a slide that was put together by one of our friends at the California Department of Ed, Monica Nepomuceno. She has been very involved with a couple of us here in the Oxford Symposium, and we meet every couple of months in Sacramento, which is the capital of California. Now we actually meet virtually. This may be a review for many of you. Suicide is the second leading cause of death among young people, and we're talking about ages 10 to 24 in California and the US. It's actually the #1 preventable cause of death. And our rates tend to be higher in Northern California, in the Central Valley, which is about 100 miles to our east, and along the eastern portion of the state, which tends to be more rural. There's been a 34% increase in teen suicides among California youth in this demographic, which is high school and the first age of transition. So many of you know that age of transition here in the US, and I think even for many countries in Asia and Africa, it's around 18 to 19. It's when they're often leaving home, or when formal schooling is done and there's a transition. We know that Alaskan Native and American Indian Native have the highest rates, and that is true in California as well as nationally. And we know that those identify as non-Hispanic white males and females have the second highest suicide rates. Now, these data come from the YRBS, and so we don't, in some of those questions, are dichotomous, those who identify as male or female, but there's a separate question looking at gender nonconforming youth and those who identify as LGBTQ. Some people are using the term SGM now for sexual and gender minority youth to be a broader, more inclusive term. But those who identified in these surveys as LGBTQ are 4 times more likely to make an attempt, have suicidal ideations or self-harm compared to youth who identify as straight. And this number is even higher when these youth come from rejecting families or communities. So as many of you know, working in schools, we are sometimes the only place where gender nonconforming youth or sexual and gender minority youth can come to be able to really feel like they have a safe place with a trusted adult, and maybe with some peers who understand some of what they're going through. And so here in California, where you might think of, oh, we're a pretty progressive place, and a lot of the major gay rights movement legislation started here, that is true. However, we also do have youth living in families, living in communities, some of which are less supportive than others. Putting this into perspective, if you have a school, a comprehensive high school of 2,000, this means you're going to have 40 to 60 every year who make a serious suicide attempt. And so when we put this number up, it's a little more sobering. And if I was on the regular screen, you would see some circles. There's a little animation there, but here's an illustration of legislation. And in the interest of time, I won't spend detail, but you'll have this in the slides. These two are probably the most important: AB 2246, which passed in 2016, and AB, which stands for Assembly Bill 1767. And these two pieces of legislation together said that all of the public schools have to provide education in suicide prevention and have to provide suicide prevention training for teachers. We must identify appropriate mental health services in schools, because of course, children in the US identify that they receive their mental health services in schools. 75% of the mental health care delivered in the US to youth are happening in schools. So 2246 was focused on students in the higher grades, 7th through 12th. And 1767, which just passed last year, serves students in kindergarten through 6th grade. And that is because we really are focused on prevention. We know that more and more we are seeing middle schoolers now presenting to the emergency departments with the characterization, or usually the mischaracterization, of mental health and suicide. It is becoming more alluring and more attractive through social media outlets and through even venues like Netflix, where you have a series like 13 Reasons Why, which may be very alluring to those who may be at high risk. And so middle schoolers now are presenting more and more to our programs. If we think about COVID-19 specifically, and we're sort of, COVID-19 is mostly awful. one of the silver linings, again, is here we are all together, getting to spend time and actually interact with each other on a screen where we can see each other. But of course, you might imagine for students, there have been way more challenges than silver linings. And so my colleague, Steve Adelsheim, who is a psychiatrist here, he's also the Associate Chair for Community Engagement in the department. His group at the Center for Youth Mental Health and Wellbeing did a study in the last month looking at several hundred Bay Area students through their youth advocacy group. And through the student surveys, they heard about several challenges. They also did some focus groups via Zoom. And so, as you may imagine, social isolation being a big one. So having students or having trusted adults like teachers check in with the students. So as we enter this school year, where in the Bay Area, all of the schooling is going to be 100% virtual, helping the teachers identify which students they want to check in on regularly, and then who might be the other people that are checking in on those students so that they avoid social isolation. Students are really feeling the decreased access to community support. So sending pictures of what's happening in other people's lives, really important. And then encountering further barriers to seeking mental health care. And while it's true that telehealth is here, I think, to stay for the foreseeable future, even as we return to in-person care, many youth still feel, for example, if they have 2 or 3 families living in their apartment, or they may be living, this student with their, immigrant parents are living in the garage of a place, they may not feel like they have privacy even through the telehealth portal. So we got to get creative. They may not have a lot, but all of our teens do have a cell phone, and they can walk out, and most of them have earbuds, which you can get decent earbuds for under $10 now, and they can walk around. I mean, we're having telehealth sessions while they're walking around their block, because that's the only place they can get privacy. Some of the additional challenges, as I mentioned, close quarters with families, economic distress. There's actually been an increase in firearms sales in California, and then the expanded media reporting, which sometimes just gets to be so much. The news is just always bad. But in addition, if we're talking about suicide, we know that one of the most important mitigating factors is if you have responsible media who can cover suicide without sensationalization and follow the media guidelines that were put out by the media for the media, you are much less likely to see suicide cluster. The opposite is true when there is sensational media, and we have a lot of that. Rupert Murdoch and his family are not just doing this in Australia and England, but certainly also in the United States, where we have people who really aspire to have that kind of tabloid presentation when there is tragedy. So minimizing risk by accessing social and community connection, increasing access to telemental health care, and then following these guidelines. And importantly, promoting stories of resilience and hope. And this is kind of the story of Headspace in Australia. We here in California, in the US, we've adopted the Headspace model, these youth drop-in centers, which has really become an international model. I'm talking about Headspace, the mental health centers now, not Headspace, the app, which also is a very good resource. But we are calling them Alcove here in the US, ALLCOVE, all lowercase letters. This is our adaptation of Headspace, and the Center for Youth Mental Health has been working. We're going to open the first 2 sites in the United States in Northern California, places where you have peer advocates, youth counselors, but adults are available as well. This is not only for teens, but also for young adults. Checking in with vulnerable group members, in particular, those who have trauma histories, those who have had previous exposure to suicide, those who are considered sexual and gender minority youth, and then implementing the media response. We've actually found the media to be quite a partner here regarding a few media outlets. So whenever there's a story they want to run, they will reach out to us, and we know that they're actually following the guidelines. So this is a brief cartoon looking at what are the targets of suicide prevention interventions. And very briefly, I'm just going to highlight that on the left here is a diagram looking at what actually happens before someone makes a suicide attempt. And on the right in blue are examples of the prevention interventions. So you all on this call are very much part of this section A around education and awareness programs, not only because we're on this webinar together, but also you might all be considered to be community gatekeepers. In other words, you're working with young people. If you see something, you say something. You're working with families. You may have contacts to community agencies or social work agencies that can help to mitigate some of the mental health stressors in the lives of youth. But here we are. We have stressful life events going on at this very moment, all over the world, in all the different corners where you're all coming to us from. Some of you are, it's 2 or 3 a.m. where you are. Even that might be considered a little bit of stress because it's impacting your sleep. Hopefully you'll get a nap later. But we know for teenagers, not only here in the US, but also in Europe, the Saving and Empowering Young Lives in Europe study, the SILE study, which all of those papers started coming out in 2015. What are the things that really help youth to thrive, and what are the things that can increase suicide risk? One of them is a decrease in sleep. And so we're seeing that a lot, not only in high achieving academic communities, but also in communities of poverty, trauma, and loss. So this stressful life events by themselves don't lead one to think about suicide. But if there is a mood or other psychiatric disorder in the background, 80 to 90% of the time before someone makes an attempt on their life, there is some kind of psychiatric condition going on, either that's been diagnosed or that's been happening for the last year. In teenagers, what's hard is the symptoms may not be as obvious. And so that is part of the challenge and part of the reasons why we need school-based family counseling and health and other trusted adults who are not in the field, but who know kids and who are in the classroom, to really be our clinical eyes and ears on the clinic side. Some of the school districts I showed in that first slide, they don't have school health centers or school health clinics. They may just have an office, it's a closet. And my intern or my resident or fellow goes out and sees kids and consults with teachers. Those teachers spend a lot of time, in particular in elementary school. And so part of some of the new interventions out there and new professional development for gatekeepers include things like virtual role play software. Some of you know the Cognito software platform, which the county here has partnered with. That's a very effective way to engage adult learners like teachers around, hey, how do you have these difficult conversations with youth you may be worried about? And there are a number of different platforms that they have developed that we find to be really useful. So you have the stressful life event, often an interpersonal stressor. We're in times of COVID, fall sports are canceled, a lot of well-being activities. You might consider these all part of the stressful life events. And then an underlying disorder, and someone might then consider suicide. And this, again, the numbers are about 18% in the US of American youth have seriously thought about it. So how do you get from here to here when you actually make an attempt on self-harm? Well, there are a number of other factors. There's impulsivity. There's a developing brain, the prefrontal cortex. It still isn't all there. That's why youth really love to take risks. There's hopelessness or pessimism, in particular in times of COVID. There's access to lethal means. Here in Northern California, it tends to be from firearms or from ligatures where they may try to strangle or hang themselves, or the train. We have learned some very valuable lessons from Vienna, Austria in the 80s, where the media decided we are just going to stop covering suicide. We're not putting it on the front page. We are only reporting it on page 5 or page 7 if we report it at all. And they saw an 85% decrease in their suicides at the train tracks, because those who are most potentially triggered with sensational headlines tend to be the ones who might then increase their risk. So access to lethal means has been a major focus for me as an advocate here in Northern California. And then imitation, which for teenagers, again, they're most vulnerable to imitation. And that's why I'm really trying to highlight the media reporting guidelines. So here in the Stanford community, we are in Palo Alto, California. We have about 70,000 residents. My wife and I have raised 3 boys here. It's really an exceptional place, but we had 2 suicide clusters that were about 5 years apart. And so what happened was they came to us and said, okay, university, come and bring us together as a coalition. And so we identified a number of community partners, for everyone from the counseling services to the other local universities, to parent representatives, the school district, the PTA, the police department. You can see a lot of different providers that may sound familiar to you in your own communities. It was really trying to bring all the stakeholders together. And so how might you imagine we all looked in those first months, right? Lots of adults wanting to do right by youth, wanting to do the right thing. We kind of looked like this. We were all full of ideas and energy, but we didn't have a lot of coordination. So it was a somewhat unstructured network. It was still a network. I mean, you might imagine if this is like kind of like a safety net and a young person comes to one of these agencies, yeah, it's going to be hard. The net may hold together, but it's really not very coordinated. And so over the course of the first few months and that first year, really, we went from this to this, which is the more intentional community network that we have now. So here we are, 11 years into this, 5 years since our last cluster. We have still had occasional suicide loss, but people are not taking their lives at the train anymore. They are finding other ways. So we live about 35, 40 miles south of the Golden Gate Bridge. We recently lost a young person who went there. So our job here was to secure for the downstream youth suicide prevention, make sure we can try and address the means issue while also focusing on the upstream. The upstream is where we have engaged adults and activated sectors with mobilized young people in the middle, with invigorated, hopefully evidence-based programs, or at least evidence-supported programs influencing civic decisions. The best example I have of this is on our school board in Palo Alto. We have about 12,000 students, and we have 2 comprehensive high schools and 3 middle schools. There are 2 students who actually sit on that school board, and they are non-voting members, but they are there, and they are a physical presence, and they are a force of nature because they are highly respected. When the adults are always trying to make the decisions for the young people and leaving the young people out, there's not a lot of buy-in. And whether that has to do with the later school start time policy, or whether that has to do with adopting a suicide prevention policy, we've got to be mobilized around the youth and with the youth if we're going to be about the youth. And so that was an important lesson for us to learn. And this model comes from the Search Institute out of Minnesota, the developmental assets model, which some of you may know about. Maybe we'll have some time to talk a little more about that in the discussion. But bringing in Bronfenbrenner, which Bronfenbrenner is everywhere, right? This social ecological model, which was developed in the 70s, probably looks very familiar to all of you thinking about school-based family counseling. We have the student nested among family and peers in schools and workplaces in a larger community and in society. So Project Safety Net kind of nests within this model here, where we've got the individual and then we have a number of the different agencies that are involved. Probably one of the biggest things I started getting involved with, actually around the time we went out to Alaska, was working with Caltrain. So in 2013, 2014, we started getting way more involved. In 2014, we had more suicide deaths, and Caltrain really came to the table. They started paying a little more attention to what their role in this was. I think they, of course, did not want to take responsibility, nor should they, because it's really suicide is really, there's not a single agency or reason why someone takes their life. And yet, we all have to feel like we're part of the village. I think Caltrain did not like the negative publicity whenever a young person took their life, or really anyone across the age span. So they started thinking more intentionally about, best practice, like putting up 10-foot fencing without toe holds so people could not scale them. The city started putting in more sophisticated video technology based on lessons from Europe and from Japan, where previously there had been a lot of train deaths, and then they were really able to mitigate their risk. So this is just an example of how we might use a social ecological model and how you might think of it in your communities. Okay.
So Sean,
yes.
Can you kind of summarize in the next few minutes?
Yes, so we have time for discussion.
Yes, thank you.
All right. So yes, I'm going to finish in 5 minutes. And I want to highlight this one, which is the culturally informed biopsychosocial model of depression. So you're all familiar with the biopsychosocial model. We think about culture in everything we do in child psychiatry here, but in particular for thinking about depression. We, of course, have the biological reasons. We have neurotransmitter reasons that depression can run in families. We know that psychologically in COVID, as I mentioned in that first slide, the kids are going from being able to use their coping skills and have healthy thought patterns to now thinking about the world in a very negative way. And while previously they might have had, family as a real source of strength and school as a source of strength, now it's being experienced differently. And so now it might actually be a risk for them. And then finally, having culture here, it's this interaction among these four that may lead a young person to experience depression. So we always try and invite our colleagues to consider culture in every student, in every patient, first beginning with an attitude of humility and being able to self-reflect, and then appreciating that cultural assessment is very complex. And sometimes we have to start by just knowing when we don't know, rather than making assumptions, knowing about our biases and prejudices, and then knowing especially when to get a cultural consultation. And this might involve youth specifically. It might involve getting someone who is coming to an IEP meeting to make sure that they're bringing not just their son or daughter, but they're bringing someone else who's trusted to that meeting. And so this is our toolkit for mental health promotion and suicide prevention. It's open source. You can simply do a search for HEARD K12 Toolkit, and it will be the first thing that comes up. And it's been compiled by a number of colleagues of mine. And the basic idea is it's got 3 interrelated sections that highlight promotion of mental health and well-being, intervention in a suicidal crisis, and then postvention if there's been a loss. Most people who find us on the web come to us in a crisis, either a mental health crisis or a suicidal crisis in their school. And so because it's available both as a PDF and on the web, people tend to scroll through and pick what they want and what they need. In promotion of mental health and well-being, there's a number of resources for best practice programs in training and education on suicide prevention, on youth mental health awareness, information for families, information on healthy adolescent sleep, on mindfulness, on social emotional learning, etc. Section 2 has a lot of fillable forms that you can adapt for your own communities. How do you build a crisis response team? How do you use a suicide risk assessment? What about younger kids who don't often present in suicidal crisis, but may nonetheless come up with some really concerning behaviors? And then finally, postvention, which is postvention is directly related to prevention. Postvention is all of the different things that happen after a suicide that balances grief support with prevention. And so this is our website, and it's heardalliance.org. We have a new update here on COVID, and then here are the resources, some of which I talked about, including the Cognito platform. And then this was the study I talked about in Europe, the Saving and Empowering Young Lives, which really highlighted some of the invisible risk kids, those who are high screen users, who are very sedentary, and who are sleep deprived. So with that, I will end my talk and turn it over to you, Alan.
Thank you, Shashank.